Okay, so we have lots of anatomy to go over. Some of this, a few of it might overlap with the pano, and a lot of these you will be able to see on a pano. But then that also depends on the pano, like if it's a clear pano. So we're going to go through these. Remember again, because there's limited time and there's a lot of slides, I'm just going to point this stuff out, and then it's up to you guys to study this stuff. So you have to just take it on to, same with the pano, as you have to just repetitiously study it. And you're not going to study it in a day. So no, so don't study it last minute for the landmark exam. You want to have done this like over and over and over again so that when you do take it, that it's an easy 40 points. Because this is like visual memorization. And this ideal, should be some of the easier kind of thing to memorize for this program, hopefully, fingers crossed. And I know not everyone's visual, but okay, so maxillary central incisors. So on a maxillary central incisor, this is just a draw up of the structures that you would see in a maxillary central incisor film. Bless you. So we're going to see the nasal septum. You're going to see the lower part of the nasal septum, but it also depends on the angle. You may see more of the nasal septum. It depends on the angle that they take the picture. You're going to see the nasal fossa, which is going to be dark because it's a fossa doesn't have anything in it very much. So it's going to be something darker. You may or may not see the concha inside the fossa. So you're going to see the septum in the middle that divides the fossa. So then you're going to see the anterior nasal spine, which is just a thicker part of the bone, and it's kind of pointy. So it's going to come down and look sort of maybe like a more radiopaque V. So you're going to see the anterior nasal spine. And then below that, in between the central incisors, the bone gets sort of scooped out and thinned out in this area where you have the incisive foramen. It's where you give the greater palatine injection. You give an injection back there, and there's just sort of a scooped out, thin area, and that's called the incisive foramen. So it's not a hole, it's just sort of scooped out. In between the teeth, kind of running through that same area, you're going to see a suture, which is also going to look radiolucent because the bone doesn't fuse there. So you have some empty space there. So that's the median palatine suture. So these things that look dark are going to be more radiolucent on the real film. Then you may or may not see a shadow of the nose. That's what this gray line is here. Again, depending on the person's anatomy and the angle that you take the x-ray, you may or may not see the shadow of the nose, and you may or may not see a shadow of the lip. So those are two possibilities that you may see. Here they are on a skull. We have C is the anterior nasal spine, A is the septum, and B is the fossa, and then you can see the concha here too, but we don't really focus on that. We don't really point it out. It's more about the fossa. On this slide here, you can see the suture, the median palatine suture, and notice that the suture runs through the fossa. So notice you have kind of this sort of thinned out, scooped out part of the bone, and that's the fossa there. Here we look at the septum again. So here's the septum going through the fossa, the nasal fossa, and then here's what it will look like on a radiograph. On either side, you see the radiolucent fossa and the septum in the middle. You can also see the suture through here as well. So you can sort of start to get in the habit, like once you start memorizing these, look for as much as you can see. Like at first you just look for like one thing at a time as you're trying to memorize it, but then try to look for more things to see what else is there. So here again, pointing out on a skull, the fossa, the nasal fossa here, and the nasal fossa here, and then the radiolucent nasal fossa on a film. Here's the little thickened kind of V-shaped or pointy part of the anterior nasal spine, and here's what it looks like on a film. Just is denser, there's more bone there, it comes out. If you look at a skull from sideways, it kind of comes out a little bit, so there's just more material there, there's more bone there. So it's going to look more radiopaque. highlighting where the incisive foramen is again, just kind of a thinned out, scooped out area. And on a radiograph, it's going to look more radiolucent. So it's going to, and see how you can see a little bit of the suture here. You lose it a little bit. The suture sort of blends in through here, and then you may or may not see it above. So it's just, but when you get asked this on an exam, which you will, notice that the arrows are they're pointing to a larger space, whereas if they were pointing to the suture, they'd come in closer to the suture. So it's really important to like notice exactly what the arrows are pointing to, because they're literally gonna like encapsulate the structure. Yeah. No, the suture, the median palatine suture is this thing that looks like a crack going down the palate. That's the median palatine suture. Okay, so here's it again. So notice, so this is what I'm saying, like notice the difference. See how the arrows are right up against the median palatine suture? Here it is on the skull. And then you can still see the incisive foramen, see it, but it's round. But that's how it's going to look on your landmark exam. You're going to have these arrows up against the suture, or if it's asking about the incisive foramen, you're going to have them in kind of around it. So I'm just trying to help you out, because that's what it's going to look like on the exam. And I've had every year people get them mixed up. And so I just want to clarify that really well so that you answer it correctly. Okay. Here's an example of the soft tissue of the nose. This can be confusing because typically the soft tissue of the nose will be higher, like it might be over the roots. And then if you see the lip, it might be more over the crown. So some of these I feel like are like, well, how are they going to differentiate between the nose and the lip? But basically, if it's closer to the roots, that's kind of laying right at the junction there of the roots and the crown. But if it's over the roots, it's probably the nose is what you're looking at. If you see kind of a shadow over the crowns of the teeth, then it's the lip. So that's just the best way to try to differentiate. Okay, so here again, we have the septum. A is the septum, E is the incisive foramen, A again is the septum, and D is the spine. And then this is trying to show a lip line. I don't think it's a very good picture, but it's trying to show a lip line right through here. I don't think that's very clear. If you're like, I don't see it, I don't blame you. It's not very distinct. Here's one that's a little bit more distinct. This one, you can sort of see a line right through here, and then you can see another line through here. So they're saying this is the nose, this is the outline of the nose, soft tissue, we're talking soft tissue, and this is the soft tissue of the lip. So that's trying to be a pretty decent example of those two things. Do you guys want to turn the lights down a little bit? Gala, would you mind just turning it down a little bit? And maybe Lisa, if you just jet that slider on the wall, if you just tuck it down just a smidge, that might help so you guys can see. It doesn't have to go all, yeah, just a little bit. That's good. Yours is pretty dark over there anyways. And if you guys want it changed, tell me. I just thought maybe that might help. Okay, so the next image, so that was your maxillary central incisor. So think about the way an FMX is set up, right? So you're going to have a central incisor film, and then you'll have canine films. So this is your maxillary canine film. So it should, theoretically, it'll be the same whether you're doing the right or the left. So here's your maxillary canine. The main things that you're going to see there is you're going to see the floor of the nasal fossa. Now, where do you think so in a canine shot, you see anterior teeth and you also see posterior teeth, right? Because you see your premolars and then you see your lateral, your canine and your lateral. So where do you think on that film, whether you're looking at a right or a left, where do you think you should see the floor of the nasal fossa? Oh, like over which teeth? Over your anterior teeth, right? Because your nose is here. This is where your nasal fossa is. And then your anterior teeth are right there. So when we look at it, this is a line indicating the floor of the nasal fossa. So always, 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 no matter what picture you're looking at, or if you're looking at a right or a left, you can orient yourself by going, where are the anterior teeth? Okay, and then this line, this more radiopaque line, would be the fossa, the nasal fossa, because that should be over the anterior teeth. And then the other thing that you'll see in is the anterior portion of the maxillary sinus, but that should hover above your premolars, right? Because your maxillary sinuses are over here. So they're back here more over your posterior teeth. So you should see maxillary sinus over your posterior teeth, nasal fossa over your anterior teeth. So you can always just orient yourself as to what you're looking at. Now they connect in something called an inverted Y. And if you look, see how there's a V right here? There's this V right here, and then there's a tail. So this V and the tail is an upside down Y. It's called an inverted Y. And so the nasal fossa and the maxillary sinus, they come together and then they make this inverted Y shape. So that's what you should notice is the floor of the nasal fossa, the maxillary sinus, sort of the anterior portion of it. And then you may or may not see, this isn't always visible, a thinned out part in between the lateral and the canine called the lateral fossa. So it's again, it's sort of a scooped out, thinner portion of bone called the lateral fossa. So here we have the floor of the nasal fossa here. We have the floor of the maxillary sinus here, sort of a thinned out area for the lateral fossa in between. Some people call it the canine fossa or lateral fossa. You might see it written in a text different ways, or people might call it different things, but it's basically between the lateral and the canine. So if we look at a radiograph, you can see this inverted Y. See, there's the little V, upside down V, and then the tail comes over here. So we have the maxillary sinus, because look, we have a premolar. So we know this is the maxillary sinus because this is a premolar. So look at the radiolucent area and then look what's below it. If it's a posterior tooth, it's a maxillary sinus. If it's the anterior tooth, it's the nasal fossa. So then here we would have the floor of the nasal fossa because here's our anterior teeth. And then sort of it's a little more radiolucent right here, and that's the lateral fossa. Showing it again on the skull, and then showing it really nicely on this anterior, on this canine shot, but it's a weird shot. The angulation is kind of crazy, but it's showing the floor of the nasal fossa really clearly, that inverted Y right through here, and then the maxillary sinus is all right here, and this is the floor of the maxillary sinus through here, because these are posterior teeth, this is a canine, and then these are anterior teeth. Do you guys see that? Some of these images will look weird, like their angulation is weird, but you can start to pick out the teeth and then kind of orient yourself. Another example of where the lateral fossa would be, sort of a more radiolucent area for the lateral fossa. The opposite side, so it's the same thing, we just flipped the film, so now we're looking at the opposite side of the mouth. So but again, same thing, here's anterior teeth. So above the anterior teeth would be the floor of the nasal fossa, inverted Y, and then the floor of the maxillary sinus, and it's the anterior portion. But even if you, on the test, if you just say sinus, I'll give you the point. Specifically, it's the anterior portion of the maxillary sinus. But if you just say sinus, you got the point. But you have to know that over the posterior teeth is going to be the sinus, not over the anterior teeth. Yeah, they're just going to be images like this with arrows, and then you have to say right in what the arrow is pointing to. Here are some more examples. So here, this one's tricky because you have your central, lateral, and canine, and you don't actually have any posterior teeth here. So this one's going to be harder at first. It's going to take a little bit more critical thinking, but you can still do it because you're like, well, here's anterior teeth. Here's a radiolucent area, so this must be my nasal fossa. Here's another radiolucent area, and it would be more in the posterior region. So this must be my maxillary sinus, and this is the nasal fossa. On this one, same thing. It's super vertical angulation on these premolars, so it's foreshortened them significantly, but you can still say, all right, here's my anterior teeth. What's straight above my anterior teeth? Nasal fossa, floor of the nasal fossa, maxillary sinus. So they look sort of like they're together, right? But it's just the angle. It's just the way the radiation, the X-ray took the picture and the angle of the film. Stop me with questions. I know I have to fly through these. There are different sinus cavities, but these are the ones that this is what we're focusing on. So we'll see the nasal fossa and the maxillary sinus. Those are the landmarks that we see. So that's all we care about. We don't care. That's all we see in like the films, the PAs, the typical PAs that we take. So that's all we care about. We don't want to know about all the other stuff because there are other things there, but we don't care. We don't need to know. If you really want to know, you can study it some other time, but you don't have to know it. And so this one is incredibly tricky here, but we're looking at the lateral fossa there. It's just tricky because of the restorations that are on the teeth. I just feel like somebody that's not as familiar with looking at x-rays might be like, what am I looking at? Because there's a broken off tooth here. So I just feel like it's a little, the canine isn't as obvious because it has a restoration. You don't see this lateral very clearly. So I just feel like it's harder. There's a lot going on that one. Okay, maxillary premolar. So now we're on a premolar shot. We're still up in the maxilla, we're on the premolar. So now we're going to start to incorporate anatomy that you can see going more posterior. So you're going to see more of the maxillary sinus. You're going to see that starting, it starts roughly around your canine to premolar area, and it just goes back. And then you're going to start to see overlaid the zygomatic process. So that's going to vary from picture to picture, but in general, it's going to look like a thick white U or J. It's gonna be pretty dense, and so it's gonna look like just a U in the corner, or maybe you'll see a little bit more and it'll look like a J. So here's some images of it. We have a little bit of it in the corner here. This isn't like a great shot, but you can see how it gets a little more dense back here around the molars. And this is what it looks like on the skull. This is the part that you're looking at. You're basically looking at like this region, like your cheekbone. That's the area that you're looking at. So it's a little bit denser back here, but all of this radiolucent area is your maxillary sinus, and then the white line that outlines it is the floor of the maxillary sinus. So if it's pointing to the white line, the best answer would be floor of the maxillary sinus. If, like I said before, if you just said maxillary sinus or sinus, I'd still give you the point. So here's a really good image. You can see this J, it swoops in really clearly through here. That's the zygomatic process. And back here, all of this part is the zygomatic arch. So you just see more of the density of the bone through there, but it's this kind of swooped U or J that's the zygomatic process. So here, again, it's pointing to the floor of the maxillary sinus, or you could just say maxillary sinus, and then you can see here again the zygomatic process, this kind of J-shaped. Here's another weird picture of a maxillary sinus. It looks very strange because you're like, what's the difference between the floor of the sinus and the bone? And sometimes this is indicative of somebody who, if they were going to have an implant or something, they'd have to have something called a sinus lift, because their sinus is literally resting like at the level of their teeth, or even lower because they lost teeth in that area. So the bone is resorbed and the sinus is like literally right there. And so if they had some kind of if they wanted an implant, then the doctor would have to go in and they like tap it up, and like they lift the sinus, and then it heals back. And sometimes they have to do grafting and stuff too. But that is the floor of the maxillary sinus through here. And you can tell because it's a big old radiolucent area around the molars and premolars. And then you can see a little bit more of a radiopaque line. And then you can see the zygomatic process through here, this kind of swoop. And through here, this is really thick. an obvious kind of a swoop right through there.
If someone's sinus is that low, are they having more sinus problems?
Very likely they could. Yeah, sometimes people have toothaches, toothaches and stuff, and if they have sinus problems, they could easily far more feel it in their teeth if they have a situation like that. So yeah. Maybe if the tooth is having a problem, but not necessarily. Usually they're prone to sinus issues in general, and then they feel it like in their teeth. So they feel the pain there. Okay, maxillary molar. So now we're going back all the way back. And again, you're just going to see the maxillary sinus. You're going to see the zygomatic process. Here's an oddball thing to add. So this is new. The coronoid process. Where's the coronoid process? On your mandible. Yeah, it's on your mandible, right? So you have the condyle and then you have the coronoid process. So it's part of your mandible. So you see it because you're way back there, and just the angle of the x-ray picks up the top little corner of the coronoid process of the mandible. So this is a mandibular structure, and you don't always see it. You just see it sometimes depending on the person's anatomy. Maxillary tuberosity, you guys know what that is in the mouth. Sometimes it's hard to see it if they have a wisdom tooth still in the bone. So sometimes you're like, what am I pointing at? And I'll show you an example of that coming up here. But that's the bony area right behind the last molar. Yeah.
The zygomatic process was the white more in front, and then behind it was the zygomatic part.
It might look different on this as opposed to a pano. So the way we were looking at it on the pano might, so things can look different. Because I know we were kind of looking at it in when we were doing pano anatomy. So try and think of them in just two different categories, because we're taking a picture in a totally different angle. You're inside the mouth with the film as opposed to outside. And there's parts on a pano that, I mean, and I've seen panos labeled with like thin little areas going straight up, and they call it, like part of the zygomatic process. So I would say what we learn in pano, just leave that for pano identification, and don't try to cross it over here. There's a few things you'll be able to, because you'll see them more clearly, but I wouldn't compare it to the pano. I would just recognize it here, like this, just to simplify it. It'll just make it easier. Otherwise, I could easily see how that could get confused. But I know what you're saying, because it was the thinner part was the process. Yeah, and really truly, so not to harp on that, but really truly, a lot of what we will point out is like just the thinner U part, which we'll call the process, and then the arch, which is like it broadens out. That is not always seen on a PA. Okay. So maybe that answered better than my first answer to you. Okay. So here we have, okay, so this is a wisdom tooth. So this is literally pointing at a tooth, but it's calling it the maxillary tuberosity, but this area is the maxillary tuberosity. So I felt like was quite confusing. Like that's literally pointing at tooth, but that's the area of the maxillary tuberosity. And you will have other examples that show it better. This little kind of radiolucent area here in the corner, that's pointing to the coronoid process, but I don't feel like that's the best example. We'll see other examples, but that's what that area is. Pretty much a rule of thumb that you could write in your notes is if you're looking at a maxillary molar, and if you're looking at this is a right film. So if you're looking at a right film and all the way posterior in the lower posterior corner by the last molar is something radiolucent, then you know that's probably the coronoid process. It's only going to be in this film, and it's only going to be in that corner, the lower corner all the way down to the molar end. So if you see it in any other corner, that's not the coronoid process. It's only going to show up here if it's going to show up. And we'll just look at other examples of it. Maxillary sinus. So we're coming down here. You can see how it looks. It's dropping down below the apices. Could just be the angulation that they took it. So that can throw, yes, you can see apices in the sinus, and it might just be the way that they are taking the angle that they took the film. And then this is pointing at the zygomatic. I would call this more the arch than the process, like you're talking about, Tammy, because it's not the narrow part, but here's the zygoma or the zygomatic. They're calling this the process, but that's not a picture that I would ever use. I wouldn't use this image and then say, what's this? I would point out an image where you can see a very defined U or J. If I'm asking you about the zygomatic process on a PA, I really try and look for images where you can tell what I'm asking about. It's not like some obscured, I never saw it look like that before. So I really do try to pick out something that's typical. Okay, another example of the maxillary tuberosity, no tooth in that one. Coronoid process, this is a good image of the coronoid process. So we're down by the molars. We're in the lower corner down by the molars. The only place you'll see a coronoid process. You won't see it here, 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 only here down by the molars. Okay, zygomatic bone or arch. So big amount of bone, so lots, like the majority of the bulk of the bone. And then the process is where it starts to get a little thinned out. This is the U or the J. That's sort of your key kind of look-see. It might be overlaid over the sinus cavity, but that's not the floor of the sinus. And so the reason why that can get, so like the angle that it's taking the picture, because you know how it goes through several structures. So it's possible that, yeah, you're looking behind that zygomatic process, you're seeing some of the maxillary sinus, but the more obvious object that you're trying to identify here is this thicker white line that's shaped sort of like a Y or a U or a J, and that's the zygomatic process. The other thing that I can say to help you differentiate is that a maxillary sinus will have, the floor will be very thin. So it's not going to be big and thick and bulky like this.
So even though the sinus cavity is right
Yeah.
you're pointing.
I'm pointing to the, yeah, or,
thicker.
yeah. So that's a good way to that's a good question, because it is a good way to differentiate, is that the zygomatic process, it has more bone, and so it will be thicker. And if I'm specifically saying locate the sinus, you'll see the radiolucent area, and then you'll see a thin line that is indicating the floor of the sinus. So that's how you could differentiate between the two. So here's a good example. So here's the zygomatic process. This is the arch back here, or the zygomatic bone. It's just calling it the bone. And then see how this whole radiolucent area is the sinus, but see how the floor of the sinus travels along here, and it's very thin. So floor of the sinus thin. Coronoid process is just a smidge down here, I guess. Here again, we have, this is another way of seeing it. This is the bone, the zygomatic bone is not as obvious, but you can see this U or J shape again, and see how much thicker it is than like the floor of the sinus. The floor of the sinus is thinner, this is thicker. And then here's the maxillary tuberosity, and then this big old kind of blown up thing is the coronoid process. So the orange arrow is pointing to this whole triangular thing, the coronoid process. So everyone's anatomy is different. So every picture will look like a slight variation of, you know, whatever we're looking at. So that's why the more films you look at, the better. And you can Google this, like Google them and just see what pops up, and, you know, try and see all different films that you can, because I have a variety, but there's only so much variety in what I give you guys. Okay, now we're going down to the mandible. Just because I want to get through this, can you just take a break when you need it? Is that mean of me? I was so good with my breaks last time. I was like timed, but there's so many pictures and I want to get through it. If you need to get up and stretch, please, or use the restroom, please get up and stretch. It will be all recorded. You can come back to it. Does that sound okay? I heard mm-hmms. Okay. We're gonna go for it then, because there's also dental materials that I would like to at least touch on. So okay, so now we're going down to the mandibular images. So I want to go back, sorry. I didn't highlight what's there. So mandibular central incisor, you're gonna have, this area is gonna vary tremendously on the angle that you take the picture, the person's anatomy. It's called the mental fossa, and it is in the general area of the root space of mandibular incisors. And sometimes it's pretty obvious, sometimes you don't see it at all. It just absolutely will vary. And then the same thing with the mental ridge. The bone thickens on down here on the inside. And depending on the angle that you take it, sometimes you'll see it really clearly, sometimes you won't see it at all. And again, it will depend on the person's anatomy. And then this as well, you might see a little small pinpoint hole. You can see it sometimes on a pano as well. The hole is the foramen, that's the lingual foramen. So that's usually pretty visible, but sometimes people have a teeny tiny one and it doesn't show up very good. And then if you notice sort of a more radiopaque outline around the little teeny hole, that's called the genial tubercles. And that again can sometimes be pretty obvious and sometimes it's not obvious at all. So obviously when I test you on it, I will pick like a really good picture. And so you can see like a more radiopaque outline to the radiolucent hole, or I might just say, what radiopaque object is this arrow pointing to? And then you need to take that clue that if it's radiopaque, it's bone. So it's the genial tubercles. And if I say, what's this radiolucent landmark that the arrow is pointing to, then take that as a clue that it's the lingual foramen. So that might be your main differentiating is the words I use. Like one's radiopaque, one's radiolucent. So you kind of want to get used to thinking of them in those two. Radiolucent is anything that comes up darker. Think of translucent, it's translucent, you see through it, it's darker. Radiopaque, think of white. It's opaque, it's more white.
So the radiolucent is
So the radiopaque is the genial tubercles, and the radiolucent is the lingual foramen. Just like this is radiolucent, it's darker. Mental ridge is radiopaque, it's whiter. Okay, so here's, you see it on the skull. So there's the little hole, that's the foramen. The bone around it, it holds like, is it a muscle attachment? I can't remember if it's a muscle attachment or ligaments. That's what the genial tubercles do. They attach, I think, muscle. And then it's just kind of pointing to the general area that would be thinned out for the mental fossa, and then a thicker part of bone coming down like this for the mental ridge. So it's kind of just have to believe that that's what it is because it's pointing at it.
This attachment to the genial hyoid inferiorly and a genial glossus.
There you go. So it is an attachment. So for two different muscles, genial, what is it?
Genial hyoid.
Genial hyoid. Oh, connected to the hyoid.
Genial glossus.
Genial, so the tongue, so genial glossus. Ah, interesting. Thank you, Lucy. So lingual foramen here on the skull, lingual foramen here on the x-ray. And this shows it, I mean, I feel like that's pretty darn good. You see a radiolucent little hole there, and then you see around it a radiopaque encircling it is radiopaque. I feel like you can see the ridge too, the mental ridge here too. And then you just sort of have to cross your eyes and squint and imagine that it's more radiolucent right through here for the fossa. Okay, again on the skull. And so here where it's the placement's off, it's not centering it, but it's more radiopaque through here. And so you would know that roughly in that area is where you'd see the genial tubercles. I wouldn't use this picture though, that's pretty bad. And then just another little interesting anomaly, it's bifurcated canine, which is highly unusual. So it has the roots are split, which is, you don't generally see that in a canine. And then the mental ridge on the skull and the really good mental ridge on a film. That's really, really pretty obvious. And you can make out a little tiny bit of a lingual foramen right there too. Just right there. Mental fossa, So it can vary in the different areas. Some areas the arrows will be pointing more toward the apices. Why might that be kind of a problem if it's pointing toward the apices? Yeah, you might think like it's a giant abscess. So generally speaking, you know, in life, like I never sat there as a hygienist and pointed out to my patient, and here's your mental fossa. You know, so it's not like that's a common thing to do. And so for the exam, just know that if it's on there, that's what we're looking for. We're not looking for any kind of pathology, even if you go, is she sure that's what it is? And it usually doesn't look super radiolucent. Like it's not like it's like all the bone's gone. It just looks more radiolucent than the bone that's around it. So here's one where I'd be like, that looks like pathology to me. It's so I don't know. The radiolucent area above corresponds to the location of the mental fossa. This is pathology. There you go. This is not the mental fossa. So I guess this was set up on purpose to give you an idea of what pathology would look like. And we do a whole talk on abscesses, and generally this very defined difference between bone and no bone is more indicative of pathology than the fossa. The fossa would be like, it's a little lighter, but not super light. So, or translucent, radiolucent. These are nutrient canals. So these are just some little interesting, you can see them coming down off of the teeth, these little vertical lines. These are nutrient canals. Okay, so moving over to the canine. So here, you're going to see a few things possibly that you'd see on the central incisor film. You might see a little bit of the lingual foramen. You might see a little bit of the genial tubercles. You may see a little of the mental ridge. Depending on the angle that they took it, you may see this inferior border of the mandible. That would just be like right through here. So you'd see a dense white line, and then below it, you'd just see nothing, like airspace. And then, of course, you may see the mental foramen, which is the terminal end of the mandibular canal, right? So the mental foramen that's down by the premolars. So here's the mental foramen on the skull. Here's kind of part of the mental ridge, the inferior border of the mandible. Here's, again, the foramen, lingual foramen, and the genial tubercles. This is just seeing half of the mental ridge on a canine shot. So it's just more radiopaque through here. So you're seeing that portion of the mental ridge on the canine shot. Again, it's a canine shot, but it picked up a little bit of the lingual foramen, and it picked up the genial tubercles. And then here's the mental foramen in between the premolars here, and then the inferior border of the mandible, lower border of the mandible through there. Mandibular premolar, so jumping back a little bit farther, you're going to see the mental foramen possibly. You may see part of the canal, and then you may see a more radiopaque line called the internal oblique ridge. It usually lies over the roots of the molars, and it's going to look more radiopaque. And then you may see a little bit of the submandibular fossa, which is just a thinned out area of bone. You can kind of feel with your tongue. It's an area where your submandibular salivary gland tucks in. So the bone thins out to make room for your gland. So you can kind of stick your tongue in and feel where the bone kind of goes in a little bit. Some of you may not. I have huge tori, so my tongue just goes like underneath this huge shelf of bone. You'd all be like totally freaked out if you saw inside my mouth. But and then I have huge exostosis up here too. It's crazy. But that's a thinned out area. So it just looks more again like the mental fossa or the mandibular fossa. Was it mental or mandibular? No, I don't remember. This is a quiz. What is it, Lacey? Is it mental fossa? So just like that, it's not going to be like it's not going to be like gone radiolucent. It's just going to be thinner. But a lot of times, especially you can see it on a pano sometimes really well, where it's like these two oval areas that look significantly less radiopaque. So we'll look at a couple examples of that. So here on the skull is where the canal would be. Here's the opening, the mental foramen, and see how it's just scooped out and kind of thinned out through here. So that's where your submandibular fossa is going to be. The internal oblique ridge rides along. You have your external oblique ridge and your internal oblique ridge. They sort of ride along together, and then one sort of comes down lower in front of the apices, and the other one on an x-ray, it looks like one just stops at the back of the molar, and it looks like the other one kind of scoops down over the apices of the molars. So that's kind of how you can pick out the difference on a film. So here we have, so like if this was a film, it would look like this one would just be coming out the back, and then this one kind of rides down. And so you can't see the external on this, but you can see the internal oblique ridge coming down through here. The other thing that it's called is called the mylohyoid ridge. So internal oblique ridge or mylohyoid ridge. Mandibular canal is going to be a radiolucent area. That can be tricky because sometimes the canal is running through the submandibular fossa, and the only way to differentiate is you might see a very, very thin white line, which is the wall of the canal. Because if you think about it, like the canal is just like a tube or a tunnel that goes through the bone. So the x-ray is going to pick up those, like the top and bottom of the tunnel, right? And it's going to look like a very thin radiopaque line. And then what's inside is just going to look radiolucent. Where the nerve is just going to look radiolucent. So you can kind of see a white line coming through here, right through here. So you can see part of it right there. But this one would be a really hard one. I would not use this one on an exam because I don't feel like it stands out enough and it's separate enough from like the submandibular. So I wouldn't use that one, but that's what it's pointing to. Submandibular fossa is usually a little bit higher up and more just a general area that looks more radiolucent. The mental foramen in between the premolars, kind of different areas, but generally, down here or up here, somewhere in between the two premolars is your best bet for where to find it. Mandibular molar. So now you're going to see the external oblique ridge, you're going to see the internal oblique ridge, you're going to see the canal and the submandibular fossa. Here's just some of these landmarks on the skull. The canal would be right around here, scooped out through here, so you can see how that's the submandibular fossa, and the internal oblique ridge comes down. So here's the external. See how it comes off, looks like it's coming right off the back of the last molar. And then the internal branches off and comes down over the apices. So it rides down through here. D is this just the large area of the submandibular fossa. Just it's going to be a big area, but see the two white lines inside? That's the canal running through the submandibular fossa. You can see it right through here. If you say submandibular fossa, I'll give you the point. If you write submandibular gland fossa, you'll get the point too. But if you just put submandibular fossa, I'll give you the point. External and internal. You have this one. I am not a fan. Every year I'm like, I'm taking this picture out because I just am not a fan of the way I feel like it confuses the issue because I like it better when you can see one end and then the other one drop down. And some of these, that's just what it looks like. But they're saying this is the external and this is the internal, but I don't really like that. And then here's the internal oblique. Basically, the internal oblique is going to rise lower and it usually goes through the apices. So if you see a thicker radiopaque line that's going down through the apices, maybe close to the, somewhere through the root or down close to the apices, that's the internal. And then below that, so you can think of it in stacks, below that is going to be the submandibular fossa. Within that will be the mandibular canal. And then you have the border of the mandible below that. So you can kind of think about it in like, if you read your x-ray from top to bottom. So again, mandibular canal, you can kind of see it through the submandibular fossa. external oblique ridge up here. Internal oblique ridge kind of comes down and is like right through here, basically, where it's a little bit more radiopaque. Same thing here, internal. Submandibular gland fossa all through here where it's thinner. External on this one, the external here, the internal down here, submandibular fossa down below that. I don't like that picture very much either. Look at these curly little roots. So here on this one, the red arrow is pointing to the canal. It's very close to the apices, so they don't want to extract those teeth because they're kind of riding close to the nerve. This as well that's impacted, these impacted molars. So what does it actually say? Usually runs very close to the roots of the molars, especially the third molars. So that's why a lot of times they'll take like a 3D image so they can see exactly where the roots are in relation to the mandibular canal. Sometimes it's like over them or in front of them or behind them, and they just don't want to get in there and nick the nerve and cause permanent numbness or damage. Okay, so let's see, where are we? What time do we have? What I'm going to do is instead of doing the let's practice part, I'm going to close out of this and I'm going to pull up the dental materials and I'm going to go over the dental materials just so that we've looked at all of it. And then if we have time still, I'll come back to this. So let me stop share and then I'm going to pull up the other one. Do you have a question, Lacey?
We don't go through all things that they do on
A key?
the, like that just answers to the questions.
Oh, yes, I can do that. Okay, so let me get. Okay. So, but the good news is that was it. That's all you need to know. Isn't that good? Like it doesn't go on forever and ever and ever. There's roughly like, and some of those things like maxillary sinus, you see in several things. So once you are like, oh, it's maxillary sinus. Oh, it's maxillary sinus. Oh, it's, you can see it in the canine shot. You can see it in the premolar shot. You can see it in the molar shot of the maxilla. And so it's really less than, it's not, you know what I'm saying? Like, it's not like every image has new things that you need. It overlaps. So you'll see the same thing in a couple different images. So, that's the upside. Okay, so dental material. So I just put this together today because there's on the end of that PowerPoint that I was just in, it has dental material that it's pointing to, but I don't think it's labeled. And I thought, well, that's a problem for people who have never worked in dentistry. You wouldn't even know what you're looking at necessarily. I mean, you might be able to take an educated guess, but so I did this because I feel like this maybe breaks it down a little bit more. And then you can go back into the other PowerPoint and then it's set up more like almost like a guess what you're looking at kind of thing. And I can put a key, I'll put a key for all of those slides that tells you so you can look and see what all those slides are. Okay. Dental materials. So why is this not advancing? Hold on. Okay. It's only 13 slides. So dental materials. So here, and I just pulled all of this from the textbook. So all of this just came from chapter 32. You can go, and there was much more that I didn't pull from chapter 32. So go in, if you have the textbook, which I hope you all do, then go in and look at all the images. It's a good chapter. It's very, very thorough. It's very, covers a lot of it. So an amalgam restoration is a silver restoration. An amalgam never looks anything but silver. And the older it is, it can look tarnished. So it can have like kind of like a blackish kind of tarnished look, but you can still polish it up and it'll look silver again. And it's an amalgamation of different metals, mercury, and you guys will learn all about this in restorative class with Kristen. So I won't go on about it, but that's what amalgam is. And it shows it's metal. So it shows up bright white on an x-ray. So it won't show up anything but bright white. So here's an example of multiple amalgam restorations close together. You know, some people, you know, will have lots of them in a row, different sizes, different shapes, different areas of the tooth, MODO, MOD, MODL, you know, and like they could have all these different surfaces that have the restoration. So different sizes. This is what it looks like when they call it overhanging. And this is no good. We don't want an overhanging restoration of any type of material, because what might happen under here? Traps bacteria. And so not only can you get recurrent decay, meaning you'll get decay around the margin of the filling, but it can trap bacteria and cause gingival inflammation and bleeding and even bone loss if it goes long enough. What else do you guys see in this picture? Do you see anything that looks fun to remove? Yeah, all these little spurs that are hanging off the teeth here, all these little spurs is calculus. So soon you'll look at that and you'll salivate. I know, you're like, wait, what? What? You'll be like, oh, that looks like so much fun. Just click, 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 click. So that's an overhang. You don't want an overhang. Amalgam fragments. Some people have what's called an amalgam tattoo, and you can literally see like a bluish hue in their gingiva, or in, you know, up in their gingiva, and that's just embedded amalgam. It's embedded into, and sometimes you see it on the inside of the lip too, or in the buccal mucosa, but it's embedded fragments. And sometimes you don't see it, but then you x-ray and maybe you see it. Maybe it's so deep that it hasn't, but a lot of times it bleeds out and you see it like as a tattoo, an amalgam tattoo. Here is a full cast metal crown. And they cast it in one foul swoop and shape it. And these are actually great. People don't get them so much anymore. They do wear, the gold wears down, but I think they're fabulous restorations. They are very compatible a lot of times to the oral environment. And it'll look like a bright white, very smooth. So you might say, well, how can I tell the difference between an amalgam, like a really large amalgam, and a full cast metal crown? Your margins are going to be very, very smooth. So notice all these smooth margins and see how choppy and irregular these margins are. So this was cut in by the dentist, carved to just fit the area. This was cast. This was cast in a lab. And so that's the difference. That's how you can tell. Stainless steel crowns are most often seen in kids, but adults can have them, especially if it's like a temporary crown. They're not ideal because it's like a one size fits all sort of. They're like small, medium, and large, and they're just not ideal for long term. And you can see there's usually like a bad margin around them. It's usually like too big. So these are not meant to be in somebody's mouth forever, but some people keep them in there longer. And sometimes they're a little bit see-through. So they're not going to be as radiopaque as like a full gold cast crown. It's almost a little translucent, like you can almost see through it a little bit. Yeah. So that's stainless steel. This is this top, let's see, to the right. Okay, so over here. Okay, so this is pointing out the post. So this radiopaque area down here, that's the post core. That's just to stabilize this restoration. There probably wasn't, they did a root canal down here. There you can see a little bit of gutta percha, and then you can see a core. So it's metal. So there's some gutta percha, which is not metal. I don't even know what it's made of. It's rubber. You dentalist will know the answer. So it's rubber, and then and so they fill the canal with that. They melt it and kind of just fill it up, and then they put in they may or may not put in a core, and then they put a crown on top of it. This is the bridge, and there's just different examples of it. Here's one that kind of looks a bit like a screw, and then gutta percha below it, and then
That might be a broken instrument, actually.
oh, a file? Oh, it could be a broken file. Yeah, you're right. Yeah. So they go in there with these tiny little files, and they remount the canals where the nerve is. And that's the root canal part. And they also have like sometimes thicker ones too that, don't they put them on a handpiece sometimes?
Yeah.
They have thicker ones. That's just, I've seen them. I know what you're talking about though. As opposed to,
I think it is.
you guys are all recalling your,
Break it off.
Usually it's a broken file.
And that would be not good. A broken file would be a very bad thing. You don't want that. You're like, really? It's not that bad. Yes. And then the root canal fails down the road and then they do implants. It's not ideal. Let's put it that way. Not ideal. Okay, so then down below here, these are all porcelain crowns. And the reason you can tell the difference here is that what you're looking at mostly is the prep. So you're looking at the prep part, and then you're seeing the part that is like the aesthetic part is going to be more radiolucent. So this is going to vary depending on like the material they use, the lab, and if they use a ceric or a 40, what's the other one? Ceric, what's the other one? 340? 340. Anyways, there's different milling machines that doctors have in their offices. And so different materials that they get or whatever labs they use, they might look different. Yeah, they prep the tooth down to like, and then they might mill their own crown, and usually they're all porcelain, or they might get it from a lab. So it just depends on the way the doctor does it. So here's some more examples of all porcelain crowns. You can see here's the base, the prep. You can see it, and then it's quite translucent. So look how similar the porcelain crown looks to enamel. Like, see, like, look at how close that is. That's really, really close. But you can tell that something's not natural there because this is a prep. That's how they've prepped down with a handpiece. They've cut down the tooth. And then we see amalgam here as well. And you can also see a little bit of a liner. See, there's like a base and liner below the amalgam. So you can pick up other little things, and you guys will do base and liners in restorative as well. I know, it's fun. It really is fun. This here is called a porcelain fused to metal crown. So this was sort of popular before the all ceramic crowns got better, like the technology improved and they became stronger. So if somebody wanted a white crown instead of a gold crown, they would be getting a porcelain fused to metal. So you get a metal core, that's the bright white, and then you get the porcelain baked on top of the metal. And the metal is usually like there's gold and silver and other things in it, and then they bake porcelain and carve it and stuff. But that's probably, they're still making them, but it's probably going out, and the all ceramic is sort of taking its place. And then this is a mix of like composite and amalgam. This is a full cast crown. These are amalgam. This is another porcelain fused to metal. So PFM for short, they call it PFM. Composites. So composites can look very different depending on the type of material and how old they are. So this composite is a little bit more radiopaque. This composite is very radiolucent. And the older composites, in the beginning, you could just see right through them, and you couldn't even tell they were there. But now they've made them more radiopaque so that you can actually see them in people's teeth. So they have different materials clearly here. They have this one, and these are all different materials. But that's composite. Okay, so here we have some gutta percha going in the root canals, and then here we have pins. And that's just to stabilize this gigantic restoration. They use pins to try and stabilize it. And then the gutta percha is for the root canal. I know. Super great. And then we have silver. They call them silver point. I don't know why they choose a silver point over gutta percha. Maybe somebody else knows the answer to that. Why they do silver points over gutta percha? Is it just an older style? Yeah. You're like, no. Uh-huh. So that's what those, so if they look more like preformed and sharp and radiopaque, then they're gonna be a silver point. If it's more radiolucent and sort of more organic to the shape of the canal, then it'll be gutta percha. And if it's thicker and it doesn't go all the way down, then it's gonna be a post. So there's a couple different ways it could look. And then what is this down here? Implant. So that should just jump right out at you because it's like, well, that doesn't look normal. Nobody's born with that unless they're like bionic. So that's a dental implant. Yeah, we'll start having children born with implants. And then this is also, so this is showing a variety. There's, the dental implants, the silver points. This is a PFM. This is a PFM. Some amalgam restorations. Here's a little composite up here. So there's just a whole bunch of stuff going on. So that's all that there may be other things that I'm not thinking of at the moment, but that's all you have to know for. There's a fun slide. Let me go back to the other one now and we'll just inlays, and I love inlays and onlays. They are so pretty. It's but they don't, I mean, they don't do them very much because they're more time consuming and oh, if they're not done well. I've seen some though that just have lasted forever. So I like inlays.
Not well, I think the ones that like no one does them anymore. So it's like really nice ones, really well cut.
Yes. Back when the dentists actually took their time.
And people, would you dote on them for having like a really nice inlay that they cut?
They're so pretty.
It's mine.
Yeah. And they'll say how much they love that dentist. Oh, he was the best, or she was the best.
For 40 years.
Okay.
You always wanna outlive your dentist.
Yeah.
Your lawyer and your doctor.
Okay. No, not here.
My dad's friend was Seattle to see his dentist. He's freaking up in his 80s. I'm like, good for that guy, but like that, if he starts coming out like tired.
Okay, I know this has been the class that never ends, and I'm sorry about that. But so we do have like 15 more minutes. So let's just, I know, if I give you a break, class will just be over. So take a break if you need it, but I'm just gonna keep going with these slides because this is like some practice session. So here's some practice. So now we're looking, so what are some clues here? What do we have over here? We have premolars, so what would be above premolars? Maxillary sinus. And what do we have on this side? Anterior teeth, so what would be up above the anterior teeth? Nasal fossa. And so here you can kind of see that inverted Y. It's not as obvious, but there's the tail of it, and it's that upside down V part right through here. So that's that. And then what would the red arrow be pointing to? Close. Coronoid process. Yeah, you were close. You're on the mandible.
Yeah, right?
Mm-hmm. Coronoid process. And what's this here? Maxillary tuberosity. Good. And then what's this bizarre looking thing here? Zygomatic process. Good. It's a very odd picture, but yes, that's what you're looking at there. Yes. And then, so the small radiolucency identified by the green arrow is what? Lingual foramen. So this kind of questioning should lead you to the right answer. So radiolucency, foramen. So that kind of is like your clue. The radiopacity identified by the blue arrow. Internal oblique, and the orange arrow identifies the submandibular fossa. So the submandibular fossa will look bigger. If it's the canal, it'll either like have lots of arrows going along the like the walls of the canal, or it might sandwich the canal and it'll look thinner. Like the submandibular fossa will just look bigger. Mm-hmm. Yeah. And then the yellow arrows point to zygomatic process, and the red arrow identifies sinus, maxillary sinus. The orange arrow points to, yep, nasal septum, and these blue arrows are pointing to what? Yep, median palatine suture. Yeah. And then what would be in through here then? Mm-hmm. That it's on this one, it's low. It's right through here. Incisive foramen, right through here. This is going to be what? This white. The spine. Yeah. That's the spine. And then what would we call this and this over here? Nostrils. Nasal fossa. Yep, nasal fossa. So the red arrows point to, I don't like this one. What are they pointing to? Okay, I think I know what they're pointing to. Yes, 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 that's my guess. I don't like that picture, but I think that's what it's pointing to, because it's kind of a radiopaque line in the area of the lower anterior, so it's probably the mental ridge. The red arrows identify the canal. See how they're sandwiching it? So that's how you go. And what is the name of the radiolucent area surrounding the structure? Submandibular fossa. Yeah. Okay, name that dental material. Okay, what do we have through here? Amalgam. What do we have on 2 and 3? Amalgam on 2. PFM on 3. Mm-hmm. What would you call this itsy bitsy little thing right here? An overhang. Yeah. And then notice this here, like, what do you see, like right through here? Yeah. See how it's not flesh, and you can kind of see this little thing here. It's like, well, is that calculus, or is that like they cut it really bad? They prep the tooth bad, and the tooth, yeah. So calculus might have built up on this poorly cut prep. I don't know really what it is for sure, but that would feel weird to your instrument. You'd be like, what the heck is that? And then you'd go over it and over it and over it. You might smooth it down a little. What's this? Old composite, and you can see liners. See, they use liners. So that's what this is that you can see, liners. And so what are these 3, maybe 4? Mm-hmm. Full cast gold crowns, yeah, and then this noble metal. Noble metal is another way to say. Yeah. Mm-hmm. Yeah. I think that my husband used to work in a dental lab. I'm pretty sure that's what he called it too. And so what is 5? A post, or maybe a pin. I think it's a pin, maybe. Part, yeah. I think they don't they put in pins around to build it up? I mean, they put in post and pins for build them.
I think post is
It won't stay. And then what about this one here? So that's going to be all porcelain. So mostly what you see is the prep, and then the porcelain's real radiolucent on this one. It kind of doesn't show up very good. And then what about this one? Yeah, I'm leaning towards stainless steel too. Does everyone agree? So. And then I know it doesn't look like a great one. And then what about? I have seen like temporary, like they'll put one on temporarily and then the patient leaves and then you can tell they don't change it. Mhm.
Sometimes do these count like do that bad.
Yeah.
Or like really, but so you would put them on and you didn't want to do like an actual count for like 18. And when it's full grown.
Mm.
Mhm. So.
When their jaws fully developed and everything. Mhm.
So we put those on.
So they can.
Then you would want to know that you know, like.
Mhm. And so then you have to probably help the parents keep it clean because those margins probably aren't great. Not ideal, but happens. So, and here's another example. This kind of looks like a band. Doesn't this look like something like an ortho band? But you can tell it's the material is probably stainless steel because it's sort of see-through-ish. Mm-hmm. And then we saw this before. What's this? Denture. What about this down here? Okay, too much side chatter. Skip it. What does this look like? It does. It looks like a lasso. They had a mini cowboy in their mouth. I think this is some metal and then they tied it. So they might have had some kind of an injury or I don't know, but it's very radiopaque. So it can't just be thread or suture because suture wouldn't look like that unless it was like made out of. So it had to be something metal. Mm-hmm. Yeah, that's a mystery, but it's got to be metal. And then what about number 12? Mm-hmm. Yeah. Yeah, that's prepped in the office. I almost feel like, yeah, it's composite, right? That's what I'm thinking too. I think it's composite. And then what about these little things down here? Amalgam fragment. And what? This one back here? So when they go to do an amalgam, sometimes you get little tiny bits of the metal. Like it can look like powder or it can look, I mean, that can just like, it will settle into the saliva and if it can embed in the gingiva and the tissue. It's not dangerous because it's not that much. And you might not even, like you rinse out their mouth good and you might not see it, but it can still get in there. And then it just lives in the tissue and it's a little bit, but I mean, it's probably not like the best thing in the world, but it's not a lot, so it's not really dangerous. It's not enough to be detrimental to their health, and they already have the amalgam in their mouth anyways. Once the amalgam hardens, the mercury can't go anywhere. Mm-hmm. It's tight in there, so. You mean like when it's in someone's mouth? Like when you're cutting it? Because there's like fumes basically, like when you're cutting it out and like they'll take a burr and they'll cut out the amalgam. So you're like you're making fumes as you cut it out of someone's mouth. But they use like a high vac, to capture, rubber dam and then a high vac to capture the. Mhm. Okay. All right, just a few. Well, there's like more than just a few more. Okay, here's a bridge with a post. I'm gonna fly through these. We just have a few more minutes. Here's a bridge with a post. This is a space maintainer. So this is just examples of how different metals will show up. This is made out of, stainless steel. And it's if a young person or an adult lost teeth, if they just leave the teeth there in the space, your teeth fall. It's just gravity. It's just life. Yep. And so your teeth will just it doesn't have anything to ride up against. And so they put space maintainers. What's this, you guys? That's a piece of an instrument. So you may do this. I've done it a couple times. It's not unusual. Did you? Well, usually, so I've done it several times, actually. And I've always fished it out. So in this particular situation, they must not have been able to fish it out. And so they took an x-ray to locate it. Worst case scenario, the doctor will have to refer them to have the tissue flapped and have it taken out. Like a surgeon will have to go in, flap the tissue and find it. That's worst case scenario. I've never had that. We have these handy dandy little magnetic tools. And a lot of times if you break, you'll never have an instrument so thin here where I've never seen a student break one here because we don't let instruments get that thin. But in private practice, I use very thin instruments. And so it happened to me. And either it kind of like was close to the top of the sulcus. So like I could just was like, and I get it out. Or there's magnetic instruments and you like just put it below the sulcus and it'll fish it out for you. So I've never had it be a problem. But if you were down at the bottom of like an 8mm pocket and you were going to town and you broke it off down there, it might be a problem. And so then you might have to like, yeah. But that's why if you're down at the bottom of a pocket, you don't use a very thin instrument. You use something that has some, some substance. A post, some root canal stuff. That's not a great root canal. That's why it says some infection. This is some pathology because you can see they perforated. Here's some more fragments. See how they're just floating around? That's fragments of the amalgam. Here's a gutta percha. Here's a post and a PFM and some more parts of the root canal. Implant. There's a little wire for something. And that's it. We did it. Okay. I know. And I'll post a key for those ones that don't have anything written so you guys know what they are. Mm-hmm.